All right, Kyle, I'm about to do a heel jar test on you. If you feel any pain with this, it means you have appendicitis.
Okay.
Ow, my foot! Put this man for surgery. Hey, Kyle, how are you doing?
Man,
long time no see.
Yeah,
actually, we saw each other on Friday, but it's been a while since you guys have seen us.
Yes, long time.
Mm-hmm. So basically, the reason for that is, Kyle and I have started the clinical part of our medical school, which is basically, instead of just like taking classes, we're also working in the hospital. So we're kind of like interns for interns.
We're like the dumbest people in the hospital.
What it means is, it's super rewarding. It's a really cool experience, but it also means we're a lot more busy. So what we're going to do is we're trying to reformat these videos a bit. We're going to make it more of a reflection on sort of what we've been seeing and what we've been doing, in healthcare and the medical profession and kind of insights we have. We're hoping that in the future we can still incorporate, we can put together some raps and do some cool stuff with that. But for now, we're just going to keep it short and simple.
Yep, pretty much. Yeah, I'll let you know how it's been different from the what they call didactic portion of medical school, where we just go to a bunch of lectures and take a test every couple of weeks and see how we've been coping with that.
Yeah, it's not like we stopped studying. Like, we're working full time and we're studying.
Yeah, and
we're also paying a lot of money.
Yeah, we're paying them to. I don't. Would you call it work? Are we working if we're paying them to?
I don't know.
That is a new. Yeah, that's a category.
It's a paid internship.
It's a paid internship.
Except it's the other way around.
Yeah.
So basically, the past 3 weeks, we've both been in internal med. That's basically it's like pediatrics, but for adults. It's kind of it's kind of everything, hard, cardiology and nephrology and whatnot. So Kyle's been on the general portion of it at the VA, and I've been doing specialties. And starting tomorrow, we're going to flip and do the exact opposite thing. So to prepare me a little bit for what's coming up, Kyle, could you tell me a bit about what it was like at the VA?
Yeah, and before I do that, I can even break down a little bit the general format of our entire year, just so people can situate themselves a little bit. So this year for us is called our core clerkship year, where we're going to rotate through all the basic medical specialties. So right now, Dan and I are on internal medicine, and we'll do that for 6 weeks, and then next 6 weeks we'll be on pediatrics. And then after that, I'll do 6 weeks of surgery, and then 6 weeks of obstetrics and gynecology, and then after that I'll do neurology and psychiatry, and then family medicine and outpatient internal medicine. So just hitting all the basics. For me, I just did 3 weeks of the VA. I spent a lot of time inside of a room, a really small room with a couple of interns and then a senior resident, right? So the internal medicine residency is 3 years, and your first year is your intern year. And then if you're a second year resident or PGY2 or PGY3, you're considered a senior resident. And then if you stay on for a 4th year and do a chief resident year, then you're the chief resident. A typical day, I come in at 7 and I round on my patients, maybe like 6:30, because then the attending will come in and we'll do rounds around 7:30. So I'm really slow at writing notes, and I'm really slow at navigating the medical records. So I want to find out how my patient did overnight and go see them and do a physical exam and just ask them how they're doing, and then come back and put in any orders, or ask the intern to put in any orders and discuss management with them, and then we'll present to the attending and do our rounds, and then come back. I'll write my notes and any other orders, and then try to study if there's any downtime. I really haven't had much downtime. A lot of the reason is because I suck at writing notes, so it takes me an hour for what would take an intern 15 minutes.
Sure.
So, but yeah, usually get out by some time between 6:30 and 8:30, and then home and eat some dinner, try to study. I really don't study when I get home. I just watch TV and...
Yeah, I know what you mean.
Yeah, I should really study.
Me too. I've barely started and got a big test coming up.
Yeah, big test. Yeah.
The specialties are a bit more relaxed in general in terms of the timing. So I'd come in an hour later, maybe around 7:30, 8, then leave a bit earlier around 5:30. So that was kind of nice. What was interesting is, so cardiology and nephrology were very different from me because I was on these two very different teams. And in cardiology, when we were rounding, we'd see maybe 3 or 4 patients a day on the particular team I was on. But in nephrology, like the kidney doctors, it would be up to 30. And it's one doctor basically managing 30 patients. And, that workload is split among maybe 4 or 5 different residents and then, a couple med students like me. But it's kind of crazy just the sheer, volume of knowledge and information these people have to be able to carry with them. Because one thing that you learn really quickly is if you look at someone's medical record, it's just it's like a massive wormhole. It's gigantic. There are so many different factors of the patient that you need to think about and consider. They might be on a dozen different medications. You have to track all of their intakes and outputs basically in terms of like food and stuff that's been coming in and out. You have to think about, okay, their history, like all those parts that you learn about medical school, like, family history, habits they may have had, medical histories, like any chronic conditions that they possess. And it's all one big puzzle. You have 100 different labs, you got to look at their sodium and their potassium and all that and present. You have to think about what's important, and then you have to present that too. And I've really, developed a lot of respect for how much work it is, because for me and Kyle, we're probably managing at most 3 patients at once, which already feels like a lot of work, but to be responsible for 30 patients,
if I have crazy. 3 patients, it's a lot of work for me.
Yeah, exactly.
Well, my interns will have up to, I think, 7 or 8 patients each, and then the senior resident overlooks them. And so he'll need to know about all of their patients as well. And then the attending comes in, and he's going to need to have his finger on the pulse of all those patients too. But it's also really surprising how much you actually do remember. Just somebody will ask you a question, and you find your mind sort of gravitating towards a particular answer. And I find myself always surprised, and if the answer is correct, I find myself surprised how often it is in the ballpark, And so there's actually a lot of work going on, I feel, in the background of our minds whenever we're learning and trying to apply these things. So it's really fun.
Yeah, I've definitely felt under a lot of pressure to be right, and it's not very often that I'm right, but I think what I've gotten a bit more respect for is we are literally just getting started on this long road. At least like 10 or 7 or 8, 9, 10 more years of training. So I think for now, recognizing that, okay, I'm in the ballpark. I might not be right, but my mind was going in the right place. I think that is something to be proud of.
Oh, totally. Yeah. And it's also funny how whenever one of the residents or an attending will compliment us, and at least this was for me, they would always qualify it for, for somebody on their first rotation, this is good, like, okay, fine. In absolute terms, perhaps not so great, but
right. You'll feel like you're putting a lot of work into it, but then that 4th year medical student, they'll be looking at the labs and calculating things. They'll be like maybe 3 or 4 steps ahead of you, like 3 or 4 steps ahead of where you thought you could have possibly thought you could have been. Have you ever hit that point, Kyle, where you're like, okay, I think I'm done. I think I have everything. And then, talk to
I can, sometimes recall the pathophysiology behind a disease, but okay, that's great. But what are we going to do about it?
Yeah, exactly. One fact that I've kind of come to appreciate. So medical treatment, it's very much based on results. So sort of the end-all, be-all of whether you should do a procedure in general is when you do that. So according to the data, according to the literature and the research, if you perform that procedure on a patient with a similar demographic, are they more likely to live or die, basically? That is what dictates what your clinical behavior is. So it's a lot less about imagination. It's figuring out what the problem is and then looking at results. Is your based on what's happened to the general population, is your patient more likely to do well or do better just based on outcomes? which is a big change for me, coming from, in college, I do a lot of philosophy. I really tried to think about, why things are happening and try to reach some theoretical conclusion, but that's not really what it's about here. It's about not seeing what works.
Yeah. It's based in science, right? But the thing is, like, that seems so banal.
Yeah.
But what I'm learning also is that, science is a little more messy than I had really anticipated it being. Yeah. So in our first couple of years here, they try to prepare us for that, and to teach us some ways to be discerning when we're reading scientific literature, or at least when we're trying to appreciate results and conclusions from a study. But there's a lot of studies that have results that conflict each other. Yeah, and depending on what science you've been exposed to, or what's come out latest, really is going to dictate, or what you're even aware of is really going to dictate your choices in management, I feel. Right. And I see like some discrepancies in the way people actually view the results. If somebody says, well, I think 5% mortality increase if you don't use this medication, or whatever, is, I don't know. I don't really trust the science on that, right? And that it's almost like there's this ambiguity that I'm starting to see in terms of medical management and the science behind it. And I don't know if that's where the art of medicine comes in, right? Exactly. You start to use your experience to determine how you're going to do things going forward.
And I do want to emphasize, there's no substitute for clinical judgment. Like, you still want to look at your patient and look at their particular set of circumstances and try to think, okay, what research applies and doesn't apply. And I also completely agree that, sometimes the conclusions of research, we shouldn't trust them blindly, because a lot of the times if you dig into the methods, you'll realize, well, okay, how valid is this, or how strong is this conclusion compared to this other paper that concluded something different. So basically in cardiology, what I found out to my surprise is a lot of the treatments for for heart disease, they don't actually affect outcome. They don't affect mortality. So it's like, even if they do, so most of the treatments that they'll do on you, they might reduce your chances of having another heart event, but overall they're actually not going to change your mortality over 5 years, which was a big surprise to me. But when I talked to my resident about it, what he said was, well, actually, when you look at those papers that say it's all, there's no change in mortality, those papers also include, all of the doctors around the country who are maybe misusing that, who aren't using the drugs properly, maybe they're not using the right dose, maybe they're not doing it on the right patient. But what my resident said is, if you are if you use your clinical judgment and you're sure that you're applying this medication or treatment to a patient that's a good fit for that treatment, then even though the literature says that there's no change in mortality, he thinks there's a good reason to believe that that patient will live longer, because, you have basically, you're using those treatments in the right set of circumstances.
I understand. So I think what you're saying is, knowing your patient well and knowing their profile medically is going to help you determine whether or not they're a good fit for a certain medication. So it's not a one-size-fits-all sort of program here when it comes to these medical interventions.
Right. So that's a lot of where that clinical judgment fits in, trying to okay, what kind of patient do you have, and will the results of a certain study or whatever apply to that? But it is just amazing to me, when my attending will ask a resident, to explain, why should we do this treatment, and the resident will just be, well, the literature shows blah blah, better mortality. And it's interesting sometimes how fast that conversation will be. And I don't know if maybe some of the nuance you're talking about is being missed, the nuance you have to think about, all the different studies out there, right? It is sort of complicated, but it's also true that in the moment, especially if you're in the ICU, if someone's in critical condition, you have to kind of use the information you have available and make the best judgment.
Yeah, definitely. And not to jump to conclusions either.
Oh, yeah.
I think one of the things that attracted me to medicine initially was this idea that I had, not that this was an accurate a representation of medicine, but this idea that
You wanted a boat?
I did. I wanted a boat first and foremost, and secondly, that it was going to provide definite answers. You're right, and I really was attracted to the certainty that I thought science and medicine could provide. And what I'm finding is that there is a decent amount of uncertainty in medicine, and how do I cope with that today? And one of the things that I and my attending sat me down and talked to me about this last week was to not jump to conclusions, to not seek that certainty that I think is very alluring for a lot of us, and I think it's a human tendency for us to do that. And so, and also, it's an energy saving matter as well to try to establish a conclusion or try to protect a pet theory that I have.
Well, Kyle, it's been really great talking to you about these first 3 weeks we've had. Unfortunately, we have class in 10 minutes, so we're going to have to wrap things up right now.
Yep.
But overall, what are you excited for going forward under these specialty clinics?
I'm excited for developing a little more competency when it comes to writing notes, presenting, and just, just those basics.
Right. And then for me, going on to the general, which is a lot more time intensive and work intensive, I'm glad I've spent these past 3 weeks building up some really cool skills. I've had some amazing experiences that'll stick with me for a long, long time. And now I kind of want to use what I've learned to excel in this new, more intense environment.
Yeah, it's going to be good. Dan's going to be with the same team of guys that I was with for the last couple of weeks.
I think I told that to Dave, and he was like, yeah, of course, the twins.
Yeah.
Yeah, we just happened to be on the exact flip-flop.
I prepared them for Dan. I let him know. I
don't think any amount of preparement is enough.
I told him a bunch of really terrible stuff. I set the bar very low, so when Dan comes in, he's going to really have that surprise factor that I think is very important.
Did you tell them to bring nose plugs?
I did not. No.
Oh, you did not prepare them well enough for my pet rhinoceros.
Oh.
He's kind of a stinky boy. He's very friendly, though.
Smelly boys.
That's how yes. Hey! If you liked our video, please like and subscribe. And if you didn't like our video, dislike and subscribe.
But please, bring some helpful commentary.
Yeah, make sure to comment with your favorite raspberry tart recipe. That would help us out a lot.
That would be very helpful.
We're very hungry.